We have 3 presenters today, Erin Rayburn, Jen Robinson, and myself. You can go to the next slide. And so in terms of financial disclosures, the only thing is that Jen Robinson is a Merck Nexplanon trainer. Erin Rayburn has no disclosures, and then myself, no other disclosures. Next slide. So the objectives today is we're going to discuss treatment of breakthrough bleeding for the implant, which is called the Nexplanon. We're also going to discuss updates and best practices for use of IUDs for emergency contraception. And we're going to review basics of choosing an oral contraceptive pill for adolescent patients. We will also review updated policies and procedures to support stocking reimbursement of IUDs and implants. Next slide. So this is everyone from the Lark mentoring program. This is our team. We're based out of the University of New Mexico Pediatric Department. The Lark mentoring program is aimed at increasing access to long-acting reversible contraceptives, also known as Lark, for all women of reproductive age in New Mexico. This is usually accomplished by training primary care providers on contraceptive management, counseling, education around Lark procedures, improving clinical flow, billing, and coding in order to help enhance patient care. Something that we also always like to remark on is that although our organization is focused on, the organization is the Lark mentoring program, we do want to say that we're not prioritizing Larks over any other method. We believe that all methods serve women throughout their reproductive lifetime. Therefore, women should have access to all methods. And with that said, Lark insertion and removal are clinical procedures that sometimes require further education, and therefore that's one of the bigger pieces that we focus on. Next slide. So it seems like quite a few of you guys have been participating in Zoom for these head-to-toe conferences. One other piece that we wanted to add is the annotate function. And so if you look at your screen and you go up towards the top, there's a view options bar. If you click on that view options bar, a bunch of options will come down, and one of them is annotate. If you click on that annotate tab, another bar will pop up. And as you can see, there will be a text option or a stamping option. And we would love to try to use those during this presentation if possible. Okay, next. So we're going to go ahead and practice right now. If everyone can stamp where they're located in the state of New Mexico at this time. So you can use whatever stamp you want, whether that's a heart, a star. So it looks like we have some people in the Albuquerque area. And it looks like maybe up towards Mora or Las Vegas, Santa Fe. I'm based in the southern part of the state. I know that Erin and Jen are both based in the Albuquerque area. So great, a little bit of a mix. Okay, thanks for that. Next slide. So before we start the presentation, we always kind of like to base our work, we like to describe a movement that's really important and dear to us, and it's the reproductive justice movement. Its focus is on patient autonomy, especially in terms of reproductive health. Sister Song is a national organization that started this movement, and they define reproductive justice as the human right to maintain personal bodily autonomy, have children, not have children, and parent the children that we have in safe and sustainable communities. So for our work, the guiding principles that we typically follow are that patients have the right to choose any method of birth control or to choose not to use birth control, free of persuasion. Patients also have the right to prompt removal of an IUD or implant for any reason without judgment or resistance from their provider. And patients should receive medically accurate, unbiased, and culturally relevant information about and access to the full range of contraceptive methods. So for this presentation today, we're going to be talking quite a bit about issues that we see a lot in school-based health centers and quite often amongst the adolescent population. And so we'll be kind of going through different case studies focusing on different adolescents. Next slide, if possible. All right, so we'll go ahead and start with case number 1. Keisha is a cisgender woman. Her preferred pronouns are she, her, hers. She got the implant about 2 months ago, so that's the Nexplanon. She says that she has been bleeding every single day, and she is called to make an appointment to get the implant removed. Next slide. So what is the implant? So for those of you who are not so familiar with the implant, it's a birth control method that's placed in the arm. It works for 3 to 5 years. It's nearly 100% effective. It prevents ovulation by thickening cervical mucus and also thickens cervical mucus. It's a low dose progestin method, so it's not, it does not have any estrogen. It does not affect bone density and is radio opaque. And it's usually placed in the arm through a procedure that's done in clinic by providers. And those can be primary care providers, nurse midwives, nurse practitioners, and also physician's assistants. And yes, so go ahead. So one of the things that we should all kind of know about this birth control method is that about 80% of Nexplanon users experience some form of irregular bleeding. About 3 out of 5 experience infrequent irregular bleeding. 1 out of 5 experiences frequent irregular bleeding, and then 1 out of 5 will experience amenorrhea, which means no bleeding at all. Go ahead and go to the next one. So in terms of bleeding patterns, they will likely establish at 3 to 6 months after the insertion process. So at 3 to 6 months, whatever bleeding pattern they're experiencing will most likely be the bleeding pattern that they have for the duration of their use of the implant. Next slide. So in terms of this patient today, when working with her, potentially when counseling her on her bleeding issue and wanting to have the implant removed, we have a couple of different statements that we could potentially say. And using that annotation capability, I would love for you guys to stamp on which one you think would be the most beneficial. So we have A, which is remind Keisha that this is common and not usually cause for concern. B, we have offer options to help manage the heavy bleeding. Oops. And encourage Keisha to stick it out a little longer to see if the bleeding improves. C, say, yes, unfortunately, this is a common side effect with the implant. Could you tell me a bit more about how the bleeding has been a problem for you? And I can see how I can help. And then lastly, D, say, it sounds like this has been really frustrating for you. We can absolutely remove your implant today. So using that stamp capability. Okay, so we've got one for C. We've got one for D. Any others? So it looks like we have a couple more for C. So I think C is a great option because you know you are kind of offering reassurance right off the bat. The one that we would typically like to see is D. And this comes from more of a provider perspective in the sense that this is something that the provider would be able to do, right, is to remove that implant. But I think also what we see amongst a lot of adolescents is that they struggle to find Lark removal services. And so one of the big things that we always want to reassure all of our patients about is that we can remove it. It's not a problem. It's something that we're able to do. After that, we can further go into information about. So next slide.
Anna, can I just throw in a little comment?
Yes.
Hi, everyone. I'm Jen Robinson. I'm one of the trainers today. And since most of you are in the role of a social worker, I think that you have a really important support role in navigating adolescents to where they need to go. Like if you work in a school-based health center that doesn't have a clinician who's trained in removing IUDs, they trust you so much with their private information. And I have loved working in places where there are social workers and counselors to help either hold a hand for a patient while we do a procedure, or just help navigate them to maybe there's a clinic in the community if you don't have the Lark removal services in your clinic. So all of this like counseling, if you feel uncomfortable with the medical content, at least like if someone's interested in getting their IUD or implant removed, you can help them get to where they need to go. All right, sorry to bug, Anna. Back to you.
And I think that's perfect, Jen. I think it's also just really important as counselors to kind of use a similar concept in the fact that reassurance is such an important piece to all of this. So if somebody is really struggling with their contraceptive method, we really want to provide them insurance about solving the issue at hand rather than constantly trying to change their mind about their contraceptive method or change their mind about having an implant or an IUD removed. So going back to Keisha, so she wanted to get the implant out. And so let's go to the next slide. And I think this has a couple more prompts there. So for our goals for this discussion, there's a couple of things that we really want to make sure that Keisha knows and receives through this discussion. One of the big things is that we really want to show that we care and we're concerned about her concerns at this point. We also want to assure Keisha that her wishes will be respected. We want to provide reassurance and anticipatory guidance. We would just want to make sure that we can help her find the resources that she needs. And we also want to really find out what Keisha's preferences are. Later, you know, with the medical provider or even with any medical professional that's on campus, we want to figure out what the range of available options are. And then we also will eventually want to make sure that she's getting appropriate care, making sure that the bleeding is not for any other reason. Let's go ahead and go to the next slide. So why is it important to reassure Keisha that she can have her implant removed? So one of the biggest things is we don't really know what her goals are. And so we really have to figure that out. If she likes the method and she wants it, and she wants some kind of treatment for her abnormal bleeding, that's one thing. Then there's also a possibility where she might want it removed altogether. Next slide. So in terms of Lark removal, what we're starting to see kind of on a national level is that a national and international level is that Lark removal is a little bit more difficult to obtain. So in this study, which was done with 800 previous Lark users that were asked about their Lark removal process, and about 27% that said that their Lark was removed later than they had wanted. And that's pretty significant. That's quite a few individuals who are not getting the services that they need. Next slide. So what are some of the main reasons why women weren't able to receive their Lark or have their Lark removed? 38% were that they could not get an appointment soon enough. 23% said that the provider encouraged them to keep it. 12% had to attend multiple appointments prior to the removal. And then 11% had difficulty finding providers willing to remove the Lark. And this is really interesting, especially with our adolescent population, because I can only imagine, we don't have right now information about adolescents specifically, but as we all know, adolescents face significant barriers, even more so than adults. And so in this situation, you know, especially with making appointments, having a provider encourage them to keep it, those are going to be even more difficult for adolescent populations. And so as support people, if we're working as a counselor or a school-based nurse, or if we're working with the adolescent population, it's really important for us to understand these barriers and see how we can help that individual overcome them. Next slide. So in terms of IUD and implant removal, there really is no preferred duration of method use. Patients often face significant barriers to IUD and implant removal, as stated before. One of the things that is being done more commonly, but not quite all the time, is that the removal process is asked or is talked about as a form, like during the procedure of when it's actually informed consent is happening. So a lot of people who are receiving implants and IUDs, they need to know before they even receive it that this could potentially be an issue for them. Patients can also have their IUD or implant removed whenever they like and for whatever reason. Next slide. So before we give Keisha a bunch of information, how do we assess that she is actually interested in learning more about her options to manage bleeding? So this is something you guys can input into the chat or annotate on the screen if that's easier for you. And just so everyone knows, Jen had put something into the chat box that in case anyone was confused, Lark stands for long-acting reversible contraceptive. And so that includes the IUD and the implant. So does anyone have any thoughts on assessing Keisha's interest in learning more about her options? So if she comes into your office and she says, I really want this removed, ask if she is interested. Exactly. That's such a key piece to this. Instead of assuming, right, we want to ask if she's interested in more information. And that's such a good way of building trust, is really meeting her where she's at. Next slide. So again, we really want to empathize and reassure her. We want to normalize her situation, and then we want to offer her information and options if that is something that she's interested in. All along, we want to make sure that her goals are listened to at the same time. Next slide. So in this situation, Keisha decides to keep her implant and asks you about options to manage her bleeding. And so with this, in order to leave the door open, we also want to reassure her. We want to let her know about her options, but then we also can say you can still have it removed whenever you want. Next slide. So in terms of shared decision-making, Keisha has invited us to share our clinical evidence and expertise with her, and is now receptive to the information in a way that she may not have been had we tried to start at this spot. So rather than starting with empathy and reassurance and talking about, you know, what she desires, with that, she is more open to clinical evidence and expertise at this time. Next slide. So on a more medical side of things, if we're assessing for, if she wants to continue with her implant use, then we're going to assess for non-implant related causes of bleeding at this time. And usually doesn't require an exam, but if there are other symptoms like discharge or dyspareunia that suggest some other issue, if she hadn't been tested for gonorrhea or chlamydia recently or has new risk factors, those are all things that we would want to assess before she continues with the method. Next slide. So for those, in terms of treatment for her spotting, we would typically look at a couple of different options. We could look at NSAIDs, oral contraceptives, and doxycycline. Next slide. And here are the different doses, which can be, and so we have a cycle of monophasic combined oral contraceptives, also ibuprofen 800 milligrams 3 times a day for 5 days can be used. Also doxycycline 100 milligrams twice a day for 5 days. Next slide. This is an algorithm that is from the CDC's SPR. The CDC has an amazing free contraceptive app, and that really shows it shows providers which methods are safe with different comorbidities. And so they also have quite a few algorithms and other information that's really helpful when assessing issues in relationship to contraception. Next slide. So in terms of kind of the shared decision-making model, we really just want to emphasize when an individual comes to you with a concern that from a provider standpoint or even from a counselor standpoint, what we really want to focus on is providing clinical knowledge. We want to provide information about side effects and medical contraindications, while also putting a lot of emphasis on the patient's value system, his or her preferences, their goals, alongside their past experiences and the influences of friends and family. So all of these things play a huge role when we make decisions about contraception as a provider and as a patient. Next slide. And I think at this point, we're going to hand it off for the case number 2, and Ms. Erin's going to take over.
Hey everybody, I'm Erin Rayburn. I'm a physician assistant and I'm one of the clinician trainers for the UNM Lark mentoring program. I practice at the Etrisco Heritage School-Based Health Center. I've also practiced at the Albuquerque High School-Based Health Center. So I work with adolescents a lot, particularly around reproductive health. I know this is a pretty, you guys are mostly social workers and counselors, and we are clinicians, so we do come from a clinical background. But I found in my work with school-based health centers, I work a lot with the counseling team and the school-based and the social workers. And I find that you guys hear a lot of what's going on with the kids. And so I think this information can be relevant to you as well. Please feel free to stop us at any point or put any questions in the chat if you just kind of want us to back up a little bit, because particularly my section here is pretty clinical. So if there's any questions around this topic that you all have, please let us know. So I'm going to talk a bit about emergency contraception. The most common form of emergency contraception that you may have heard about is Plan B. And I would imagine you've heard about this from some kids. But I'm going to kind of give you guys an overview of all the different options that can be used for emergency contraception. And I think from your standpoint, knowing how different patients, how these kids can access these different options is really helpful. So we have Sarah, she's 17, And she's coming into clinic for her Depo shot, which is the birth control shot. She really doesn't have a medical history. She has a BMI of 36, which is considered obese. She had her last period started 9 days ago, and she had unprotected sex 3 days ago. And she is worried about becoming pregnant from that sex 3 days ago. She's not seeking pregnancy. So what is emergency contraception? Emergency contraception is contraception, so birth control, that works to prevent a pregnancy after unprotected intercourse. So unlike regular birth control pills, implants, IUDs that are preventing pregnancy before intercourse, this works after intercourse, but before a pregnancy has implanted. It doesn't disrupt a pregnancy. So if there's already a pregnancy, it doesn't disrupt that pregnancy. And you want to use it as soon as possible. So if you have patients that need this, if you have kids that need this, you really want to help them get to a clinician or a pharmacy that can provide this care as soon as they can. There's different types of emergency contraception. So the copper IUD, and also now the hormonal IUD, so those are devices that get placed inside the uterus. Those are the most effective forms of emergency contraception we have now. There's also 2 forms of pill emergency contraception. One of them is the Plan B pill, or levonorgestrel. That's the progestin that's in the medication. The other medication is ulipristal acetate, which is also called Ella. You also can have somebody take a large amount of their birth control pills for emergency contraception if need be. So the levonorgestrel, there's a quick overview of what the IUDs are. Levonorgestrel IUDs are hormonal IUDs. There's several different kinds, brand names, the Mirena, Liletta, Skyla, and Kylena. They work from 3 to 7 years, depending on what the device is, and they're very effective. They have a low dose of a hormone called progestin, and they can be really helpful for a lot of kind of non-contraceptive benefits. So they help with people with bleeding and sometimes pain around their periods. There's also the copper IUD, which lasts up to 12 years. It's 100% effective, and it's the most effective non-hormonal method. It's also the most effective form of emergency contraceptions. This is a really good thing to know for patients who want really effective emergency contraception. I think that the barrier often for particularly adolescents is being able to get this method. It's nearly 100% effective. It's more effective than the pills, and it works. It's more effective for patients who are over 165 pounds, whereas the pills sometimes can decrease in how effective they are with weight. It can be used up to 5 days after somebody has unprotected intercourse. And it does disrupt fertilization, but does not disrupt a pregnancy. So it stops a pregnancy from implanting. You can't use it if somebody has a cervical infection or is pregnant already. And it also offers contraception. So once they have it, they have birth control. I'm going to go over the pill forms of emergency contraception too. So Ella is a pill that you get from a clinician or the pharmacy. It works up to 5 days after unprotected intercourse, but you want to take it as soon as you can. And it works by preventing ovulation, so preventing the release of the egg if that hasn't happened already. You don't want to use it with somebody who's already pregnant. Sometimes people feel a little bit nauseous with it, and it can change their period. So the big thing about this is a lot of school-based health centers, a lot of different medical offices don't carry this, and you usually need to get it at the pharmacy. It does require prescription, and it's not at every pharmacy, but it's an important one to know about. The Plan B pill is fairly common. A lot of school-based health centers carry this. It's a dose of progestin. You take it once within 72 hours, ideally, of unprotected intercourse, but the sooner the better. It also stops ovulation, so prevents the egg from being released if that hasn't happened. And it reduces pregnancy by about 87% if taken kind of in the right time frame. It's very safe. Pregnancy is a contraindication, but only because it doesn't work if you're pregnant already. There can be some similar side effects like headache, nausea, or change in the period. It does tend to decrease efficacy with weight. This is over the counter in New Mexico. teenagers can go to the pharmacy and buy this if they need to. They can just ask the pharmacist if it's not in front of the counter, but they can buy this. We dispense them at school-based health centers, and if they have a prescription, Medicaid covers it. So this is an important one to know about. And I think from your standpoint as social workers and counselors, it's important for you to know about this because kids can access this even without a clinician. So I like this chart because it gives us kind of an overview of the different forms of emergency contraception and what we'd want to think about. So the IUD, like we were talking about, that has to be placed by a provider. It's placed in the uterus. It is most effective and it works up to 5 days later, but we have to have access to that, right? So you have to be in a setting where the provider is placing these and where the timing works. Ella is that pill form that does require a prescription and can be you can get it from a pharmacy, or some school-based health centers have it. Plan B is very common in a school-based health center setting, and patients can also get it at the pharmacy without a prescription, although it's covered if they have a prescription. This is a chart from the CDC about how to tell if somebody could be pregnant. This is a helpful resource if you're going to be starting methods of contraception, or if you're worried they're already pregnant. And I'm not going to go over the whole thing because you guys can see it, and I don't know if it's terribly relevant to you guys. And so just another quick rundown, when we think about different forms of emergency contraception, we have the pill forms and the IUDs. So the IUDs, you can use a copper IUD or a hormonal IUD, but you have to be able to get this patient to a provider who can provide these, and they are the most effective forms of emergency contraception. And then you have the pill forms, Plan B or Ella. Ella requires a prescription. So if we think about weight, the part of the reason the IUDs work really well is they don't decrease efficacy. They don't decrease how effective they are with weight. So the Plan B pill, it decreases kind of as soon as you're considered overweight, which is a BMI of 25. Ella starts to decrease in effectiveness after a BMI of 30, whereas the IUDs don't decrease in effectiveness. So they're important that we think about these methods. So after talking to this patient, she decides that the copper IUD is what she'd like to use. And because it's so effective, and she also likes the idea of having it for ongoing contraception. So she'll be covered now from pregnancy, and she won't need to have emergency contraception so frequently. So I'm just curious, do you guys work in settings where your school-based health centers provide IUDs? Do you know? And if you know, can you annotate on the screen and tell me? Okay, we've got one yes. Yay. Another yes. One no. Yes.
I'm sorry, but mine's not working.
Oh, you want to just tell me then?
No, yeah, it's no, but I'm sorry. I can't get it to work.
That's fine. I know that the annotation can be a little bit tricky. So yeah, we've kind of got a mix. And so I think, in terms of school-based health centers, some providers are providing IUDs in the school-based health center setting and some aren't. I think this is a really helpful thing for you to know, whether your students do have access to IUD placements. And I think asking the providers you work with if they have access to IUDs for emergency contraception, so like that day if they need it. And just getting a good system in place with the provider you work with so that you can get those kids to them quickly. If they don't provide this care in the school-based health center, the health departments do. So the health department's another option. Sometimes I've found, at least with my adolescent patients, they need a little bit of guidance in how to get to the health department, but the health department has Title X funding for adolescents and can provide this care. If you're also in a setting where you think your providers might want to learn how to place IUDs or implants or want more information, hook them up with us because we can help them start that process in the school-based health center setting. Jen and I have both been school-based health center providers that place IUDs in that setting, and it definitely is possible and very safe with training. So same day placement that's the big issue with emergency contraception, right? You have to be able to get these kids this IUD right away. So the nice thing about being able to do same day placement is you can do it anytime in their menstrual cycle. You do an STD test, and IUDs and implants, which we're talking about a lot, they don't protect from STIs. So we want to talk about condoms also. We wouldn't want to put an IUD in somebody who is pregnant, who has a pelvic infection, or has something going on in their uterus that makes it not possible for us to put that in, or if they have endometrial or breast cancer. That's not very common in the adolescent population. And again, we talk about condom use with these patients. So as Anna touched on, removing these is a big deal when we're talking about IUDs and Nexplanons. And I think you guys tend to hear this stuff often too. I've found a big worry for my students is that they're not going to be able to get these removed after graduation. So thinking about resources for them, if they can't come back to the school-based health center, if they don't all of a sudden have funding that they had with the school-based health center, where can they go if they need this care? And again, I think the health department is a really, really great resource, and also just knowing the resources in your community. Patients can remove their own IUDs, and we're trying to talk more and more about that, particularly with COVID, because a lot of clinical services are virtual or access is being limited. So that is a possibility. And about 1 in 5 patients who try to remove their IUDs do it successfully. Here's some tips for self-removal. It's helpful if the patient's squatting or lying down, uses their fingers to feel for the IUD strings. And then if they have an exam glove, they find those strings and they just put some gentle, they pull gently, and the IUD is often able to be removed. So I know that was like very clinical. Does anybody have questions for me kind of on emergency contraception, on any of that stuff that came up? Or really just any reproductive care for adolescents at this point?
Do you have any info about the new type of birth control that's coming out? That they don't have to use it every day, and it's like a lollipop stick, or it's like a new thing, and I don't understand it.
I love the idea that there's a lollipop stick, but I don't know. Jen, do you know?
Well, I'm wondering, do you know, are you maybe talking about the implant that goes, it's like the size of the implant is the size of a matchstick, and it's flexible, and it goes under the skin in the arm.
Oh, no, this one, I guess you insert it like a tampon, and you only use it, I guess, when certain times, and you don't have to use it all the time. But I didn't understand what they were talking about.
Yeah. Yeah, that's a great question. So there are a few new-ish pregnancy prevention options that are FDA approved. And one is a ring, which I don't think is what you're talking about. So we've had the Nuva Ring on the market for a long time. And that's a ring that's like, usually I have one as a paperweight on my desk, but of course I don't have it right here right now, but it's about this big, and it's changed every month. Then there's a newer ring called Anovera. And I would say more than a lollipop stick, it's more like a really big, flexible lifesaver, like the lifesaver candy. My understanding for the Anovera ring is that it works for 1 full year, and patients can put it in and take it out to have a period. And then the thing is with the Nuva Ring also, people can take it out for up to like 3 hours, like if they wanted to have sex, or if they wanted it out while they exercised or whatever, they just have to remember to put it back in. Then there's like a new spermicide. Erin, do you know about that? I think it's called Flexi. Yeah, is that Anna? Do you think that's what you were thinking of? It was Anna Gallegos with the question, right?
Yes. I'm not really sure because I got the information so quickly that I was like inundated, like what? Well,
I know, yeah, it's hard to keep up with everything that's coming out. So There is something, and I don't know if we have the capacity, Alicia, to do a follow-up email. Usually we do a follow-up email and to provide more information and resources, which if that's possible, I sure would love to send you the information that I have about that new spermicide that's on the market. That's more effective than previous spermicides.
Yeah, I send out a follow-up email
Okay, great.
the day after with
Okay.
a link to our evaluation and everything. So if you want to
Okay.
send me anything that you want to provide, I can add it to that email.
Okay, great. And then we'll also provide a link to some of the resources that we're reviewing, like some of the patient education handouts with the websites and stuff that we like to use that are super, super appropriate for social workers and counselors to provide. If you don't feel comfortable going through all of the options, totally understandable, but at least you can say, looking at this website is way better than just Googling, because people come in having Googled things that are terrifying before they see us. And I like to be able to give them a website that I trust that has good information. So we'll definitely include information. I'm pretty sure you're thinking of like a spermicidal film. That's kind of like, I don't know if y'all have seen those like Listerine strips that you like put in your mouth and it dissolves. So I think that what you're thinking of is maybe something like that you put inside the vagina and it dissolves. So we will send out that extra information in addition to the other resources we're going over.
And then we have a question here. So how do you suggest we keep Plan B on hand at the school? Is that possible? Our school health center providers are not always on site, and it can be tricky to get Plan B quickly for them. Yeah, this is really common. It's really hard when you're in a school-based health center setting where there's not a provider all the time. Usually a provider has to dispense it. I think the other thing to talk about with the providers is if they can provide prescriptions ahead of time to their patients who are on pills or aren't on a long-acting method, so that the patient can have that prescription and they can go to the pharmacy and get it, because they can go to the pharmacy and get this even without a prescription. And then the health department is the other option. But it is really tricky because at the school-based health centers, you have to have a pharmacy license to be providing Plan B. And then usually a licensed provider has to dispense it, or a nurse sometimes if there's a standing order. So it kind of depends on where you are. And if you're having problems with that, if any of you want us to reach out to your providers or work with them about how we can kind of create more sustainable systems, we're happy to do that. So just let us know what school-based health centers you're working with.
And another great thing that we could try to help with, if that's the case, because a lot of school-based health centers have a provider, they're like 1 day a week, or maybe not even that often, maybe more often than that. So we are connected with the Alliance for School-Based Health for New Mexico, and they really know what folks all around the state are doing. And it's super helpful to reach out to us. And then we kind of like throw the question out to them, like, what have you seen work in other school-based health centers in New Mexico? So I would just say the first thing to know about your specific site is if you are allowed to keep medications on site at all, like Erin had said, because school-based health centers need a pharmacy license to have and like dispense medications. But definitely I know that a lot of clinics where I've worked, not necessarily just school-based health centers, have what Erin described as a standing order, where the provider has this like general order in place. And that would be something that we would be super, super happy to help brainstorm around. And so Erin, do you want to put our emails in the chat? And then you can reach out to us or Andrea's, I don't know whose email you want to share, but we're really happy to help kind of brainstorm around that. Because I know Erin and I both worked at Albuquerque High, and man, that place was like a Plan B, like bonanza every day, which was so great for us because we had this opportunity to connect with the students and get them what they wanted, what their priority was, establish trust in a relationship, and then make plans for them to come back and see if they wanted other forms of pregnancy prevention, just to let them know that we were there, or other services that we provided. So sometimes Plan B is a great like gateway into receiving services at the school-based health center. So really great question. Any other questions that have come up about reproductive health at all? Because we have plenty of time to go over this stuff with you all, and the rest of the slides we can get to them, but we really want to know for you and your roles what we can help support for you. So you can throw it in the chat box or just unmute yourself and shout out because it's a small enough group. So if there's not anything else right now, I'm going to go to the next case, but please, as you think of things, like, don't be shy, just unmute and shout out if that's allowed. And then throw things in the chat box too. So the third case is a 17-year-old named Jane. Jane is cisgender. That means that the gender identity that was designated at birth, a female, aligns with her identity as a female, and she likes using she, her pronouns. She has migraines with aura, which means really severe headaches with like a funny feeling in her fingers or seeing spots or stars before the pain of the migraine starts. She also has really severe period cramps. And she doesn't really know if she wants to be pregnant, but for sure she doesn't want to suffer from her cramps anymore. And she does not have insurance. So I have seen a ton of patients, especially at the school-based health center, that didn't have insurance, weren't going to qualify for insurance. And so if y'all have any questions about navigating care for uninsured patients, we can also talk about that. And we will talk about that a little bit on the upcoming slides. We'll go to the next one. This is a slide that just has some basic information about a resource that I love, which is a book and a website and a conference. And so even if you're not a medical provider, your role is so important because you're so trusted by these adolescents. And if you were like just dying to get more information about the stuff that we think is really fun and exciting, the conference is excellent. And I think would be amazing because in your role, you are well suited to do a lot of health education. So the book is probably like a big old read. It's like this thick, but there are resources online associated with the whole contraceptive technology conference and book and resource. And a lot of the upcoming pictures that I'm going to use in the slides come from this contraceptive technology resource. So we'll include that in the follow-up email. Super, super helpful. Tell your friends, tell your clinicians that this is a really great resource for providing reproductive health care to all people and adolescents. Go to the next slide. So I know that we've talked about emergency contraception and IUDs and the implant, but we just want to really reiterate that we aren't talking about those methods because we endorse prescribing or using one of those over another. And so something that you all might not have gotten in your training as social workers and counselors is just a way to think about or categorize all the different methods of contraception. Why do I think this is important? Well, sometimes patients say, I don't want any hormones. I don't want to use any hormones. And if you wanted a reference to be like, oh my gosh, I can't think of all the options that are hormone free, they're laid out here on this little pie chart. And you can see that the copper IUD is highlighted there because it is the most effective non-hormonal method that is reversible. And we don't do any permanent stuff for teenagers. So that's what I always say to them. And I don't know if you all have heard this from your teens that you serve, but there's so much concern about permanent impact on ability to become pregnant in the future with use of any method of pregnancy prevention. And so especially hormonal or IUD. So I always want to make sure to include in my anticipatory guidance, just like, hey, I just want you to know we don't do any permanent stuff for teenagers. So anything that we're talking about today is not going to have a long-term impact on your ability to get pregnant in the future, which means that, you know, once it's out or once you stop using it, your ability to become pregnant comes back to what it was before, unless you had something else change in your health in the meantime. And I will put a little footnote and say, sometimes it takes 1.5 years for regular periods to come back and for fertility to come back after the depot shot, and the depot shot only. So other ways to conceptualize different methods of pregnancy prevention are looking at from the hormonal options. There are 2 types. One type is the progestin only. You can see on the top left part of the pie. That means that they only have one hormone in them, that is progestin, and that is something that is more of an option for people that have medical conditions that make estrogen unsafe for them. So I have some patients that come in and they're like, well, whoever doctor I saw before said I couldn't use any hormones. And I just try to get, if we have access to their chart and their records, so great. If not, we just go fishing through their history that they have in their mind. And so tell me a little bit more about what they said. And you all in your roles, maybe it's not your job to go real deep into it, except to know that you can tell your patients, you know, there might be some options that have hormones in it that are safe for you, because not all hormone birth control options have the same hormones in them that people can, you know, be more likely to have a problem with. So you're not going to be like, well, you can use this and this and this, but not this. If that's outside of your comfort zone, obviously don't do that. But you could look up with them like, okay, which options have which hormones, if they wanted to know that. So the most common hormone that people will have medical conditions like migraine with aura, which is what this patient in this case had, or really severe high blood pressure, or had a blood clot or heart attack or stroke before. Not super common in our teenage population, but these things still happen. People with those contraindications or medical conditions, it wouldn't be safe to do estrogen containing methods for them. So all of the long-acting reversible methods, which are the IUDs and the implant, do not have estrogen in them. So they're safe for most people to use. And they're reversible. And I just do want to say also that that we don't really use the term long-acting reversible contraception when we're talking with our patients, because it's like a mouthful, number one. And number two, we don't want them to think that they have to use these methods for a super long time. Just because they can work for 12 years for the copper IUD, 7 years for the hormone IUD, 5 years for the implant, doesn't mean they have to have them in that long. If they want them taken out at any time for any reason, we can help them with that. All right. And Erin wrote in the chat, bedsider.org is a great resource for you to peruse for yourselves to know more about birth control, and then also to share with your patients. That's one of those really great evidence-based and not boring websites to go to. All right, let's go to the next page. This is a handout that we use all the time. I use this every day that I'm in clinic. And I don't know if you can see it that well, but we'll include information in the follow-up email about how to order this for your clinic. It's something that is a resource that comes in English and Spanish, and it's from a collaboration between bedsider.org, the website that Erin had just written in the chat about, and the University of California, San Francisco Beyond the Pill program. And so what I like about this chart is that it is not boring to look at. It has correct and accurate information, and it has these pictures that really help us kind of explain and demystify what's going on. So the way that it's set up is to have the most effective methods at preventing pregnancy on the top, That's the implants, the IUDs, and then sterilization, which we don't do for teenagers. And then the next most effective methods at preventing pregnancy are pill, patch, ring, and shot. And then the methods on the blue line are the methods that don't work as well as the other things because they need to be done every single time that someone has penis and vagina sex. So the way that I use this chart is not to like go through every single method and talk about every single method, because that would take forever. And it's not necessarily meeting the patient's needs, right? Because this chart, the way it's laid out, kind of assumes that everyone's priority is always preventing pregnancy more than anything else. But we know from this case study for this patient that her main priority is treating cramps. She doesn't want to have her cramps anymore. She doesn't really care if she's pregnant or not. She just doesn't want to have cramps. And so the way that I would approach this patient coming in is we definitely can talk about options to help you with your cramps. Would you like me to go through all the birth control methods that could help you with your cramps? And sometimes I have patients that are like, no way, I don't even want to talk about birth control. I just want to talk about how to treat my cramps, not with birth control. And so in that case, we talk about like high dose ibuprofen or high dose naproxen, exercising on a regular basis, heating pad, all these other things. But if they were interested in looking at birth control options that could help with cramps, I would go through the list, look on the first line and say, okay, the implant and the hormone IUDs, or any of the options on the green line, for all of those options would help about 4 out of 5 people with their cramps. So pretty good chance with any of those options that they're going to help your cramps. If someone has super severe period cramps and it's because of a condition called endometriosis, then we do know that the hormone IUD and the implant and taking the birth control pill in a way that they skip periods, those are the most effective at treating cramps. So just so you know, that's kind of an example of how to use this chart, identifying a patient priority first and then going through it rather than just like line by line every single thing. Erin, anything else to add about that? Your chart. Okay. So I had mentioned the way that I go through talking about birth control options with my patients is asking them what's important to them. So I like to tell the story about how I had no idea when I started providing care to adolescents that some adolescents wanted to become pregnant, and some adolescents were kind of like, well, if it happens, it happens. I'm not trying, but I'm not trying. And I came from a background where I hadn't ever considered that perspective, and I wasn't around people who did when I was growing up. And so it was a learning curve for me to realize, whoa, I got to slow my roll. I have to back up and ask my patients if they even want to talk about birth control, if they even want to prevent pregnancy, or, you know, what are they wanting from the visit? And so I'm not assuming that people want to prevent pregnancy, because my patients were super kind when I was always assuming that. And they kind of like meekly would tell me, because we had enough rapport and trust that they'd be like, well, I kind of am okay if I get pregnant. And I was like, oh my gosh, I was totally missing the boat there. So I would just say, like, you all probably, hopefully, if you have that relationship already established with patients, you kind of know where they're at with that. So you can provide really patient-centered care around kind of what their goals are. So some of my patients say, well, like, I've like had this conversation many times last week, actually. I don't really want to get pregnant right now, but maybe like within the next year. So I would like to have my IUD or implant taken out, and I'd like to change to start something that I can start and stop myself, like the birth control pill or the patch or whatever. And so if that's something that's important to them, I'm not going to like be like, but the implant, it works so well at preventing pregnancy and you don't want to be pregnant right now. But, you know, like if they're telling me their goal, the way to like establish and maintain rapport is being like, okay, I'll totally do whatever you want. Because I want you to trust that you can come back here and get what you need. And then non-contraceptive benefits are another reason that, you know, we might see like, oh my gosh, it doesn't really seem like your life is in a place where pregnancy would be something that I would be comfortable with. But you're identifying treating cramps, most important thing for you. Okay, so we're going to focus on that, even though I think I would have different goals if I were you, which is kind of for me, it was a very personal process of recognizing my discomfort and my preference for what I would choose differently, and then like recognizing it and just setting it aside. I don't know, Erin, if you have had that experience. I think we've talked about it quite a bit. It's hard, but important. So let's go to the next slide, please. So these are benefits specific to the birth control pill and the patch and the ring that have both estrogen and progestin. So the birth control pill, where there's like 24 tablets or 21 tablets of one color, and then 4 to 7 tablets of another color, that's like the most common way that people have their pill look, and that's a combined estrogen and progestin pill typically. And then the patch and the ring only come in formulations for pregnancy prevention with both estrogen and progestin. So what do? They can decrease cramps. They can decrease the amount of bleeding. If some people have anemia or low iron from having heavy periods, they can help reduce the anemia and help people build back their iron stores in their body. And there are some, mostly pills, that can help reduce the symptoms of premenstrual mood changes or physical changes that people have in the 2 weeks or less before the period. There's less risk of people having certain cancers like cancer inside the uterus, the ovaries, and ectopic pregnancy and pelvic inflammatory disease. So it doesn't prevent sexually transmitted infections, but they can prevent those infections from climbing up inside the uterus. All right, let's go to the next slide. So this is that really helpful resource that we've been talking about, that I would say, like, if you know that the clinicians in your clinic sometimes have trouble figuring out like what birth control method is safe for the patients, or if you are getting a lot of questions, the clinician isn't there, you kind of just want to know, like, so you can help your patient figure out what they would qualify for or what would be safe for them. This is a free app that I think is pretty easy to navigate. It's also available as a chart. So the CDC medical eligibility criteria is updated at least every year by people who are experts in pregnancy prevention and family planning across the country, and they read all the newest research and they update their recommendations. So the way that it works is you can search by condition, like high blood pressure or migraines or whatever, and then you can look at all of the different birth control methods and see if it's basically green means go, red means no. So 1 and 2 is like, yeah, go ahead and do it. There's not a concern. 3 is like, maybe would be good to talk to an expert in this, you know, in family planning, or do really a lot of shared decision making with the patient and document that. And 4 is like absolute contraindication. No, we're not doing that here. So this 1, 2, 3, 4 resource was actually developed by the World Health Organization initially for people that work in pharmacies without a clinician or someone with advanced training present. So people that don't have medical training that was very extensive can actually help navigate what prescriptions are safe for people. So this is something that if you're like, oh my gosh, I don't know, but sometimes I get these questions and I kind of want to know how to address it, this is a great resource that I think is appropriate for social workers to know about too. All right, let's go to the next slide. This is just a little snapshot of some of the information that you could access from this resource. I do want to point out a very common concern that people have that that would be a contraindication or like a medical issue that would prevent people from accessing birth control is if they use tobacco or if they smoke. So I just want everyone to know that our patients, if they're under 35, even if they're smoking a ton, it's not like, yay, we're so happy you're using tobacco, but we can know that if that's the only thing that they have that's medically concerning, they don't have any other contraindications, it would be safe for them to use any method of contraception, including estrogen-containing methods. So that's just an example of what the chart looks like from just pulling out like the most common contraindications or medical issues that would make it so it wasn't safe for someone to use certain methods of birth control. But you can see that the copper IUD and then this, yes, Anna, Did you have something you wanted to say? Okay. So the copper IUD, this LNG IUS, that's the hormone IUD. And then the implant, you can see for most conditions where people might have a contraindication or a medical condition that makes it so they can't use estrogen, the IUD and the implant are safe for them. All right, let's go to the next slide. So again, just to indicate which conditions would make estrogen-containing birth control not safe. If people have a history of a blood clot, whether it was in their leg or their heart or their lungs or their brain. A migraine with aura, which is like a really severe headache with weird stuff that happens to them before, like tingling fingers, seeing spots or stars, things like that. Really severe high blood pressure, heart disease, and some forms of liver disease. Those are medical issues that if someone has that, then it would not be recommended for them to use methods that contain estrogen. So let's go to the next slide, please. All right. It can feel super overwhelming to choose a birth control pill that would be a good option for your patient if that's what they've identified that they want to use. So we're just going to go through. We know that most of you are not prescribers, and so it can help. And I will tell you what, I've had a lot of patients come in to see me in clinic and they've brought their packs of birth control and it looks like they just randomly selected whatever pill they felt like and they weren't taking it in the way that would help them actually prevent pregnancy or obtain the non-contraceptive benefits. So you all have really important roles, especially where there's not always a provider available, to help troubleshoot these things and to help provide education to your patients about the best, most effective way to take the pill. So let's go to the next slide. So in this case study that we're talking about, this patient did not have insurance. And so there are pharmacies that have discounted medication lists. So often there's a birth control pill called Sprintec that we don't promote one pill over the other. But the reality is that's the pill that's on most of the inexpensive medication lists for uninsured people. Typically, it's about $10 a month. There is also something called goodrx.com where people can get coupons to use with a prescription that can also be used to bring down the cost of Plan B for uninsured people with a prescription. And so in general, generic versions of pills are less expensive. And it's really helpful for you to help your providers if they're not doing that. Just know to prescribe the least expensive options for the uninsured patients if cost is a barrier, which it often is. All right, let's go to the next slide, please. Okay. I have found working with adolescents that taking a pill that changes, like the week changes color, so the pills would have like 3 or 4 different colors in each pack, is like extra confusing for people. And that's the kind of pill that's called multiphasic. So a multiphasic pill is where there's different combinations of estrogen and progestin every week. Then you can see the examples on the screen here. So I have found personally that monophasic pills that have an even amount of estrogen and progestin hormones throughout all of the active pills is easier for people to follow. And the other benefit of that is that if patients wanted to skip a period, they can do it with those pills, but they can't skip a period with the pills where there's, the 3 or 4 different colors in each pack. Next slide, please. Another option that I had mentioned before is the option of a pill that comes in a pack that's like a book. And inside the book, there would be, and you can see it here on the page, 3 different pages or 3 different kind of sheets of pills. So the first 2 packs, you might be able to see, I think you can see okay in this picture. The first 2 packs or the first 2 months of these pills have all the same color, which means the amount of hormone in each of those pills is the exact same. And then you can see the third kind of page of that book has 21, well, you can't say all 21, but There are 21 tabs there of all the same color, and then there's 1 week of a different color. The seven tabs at the end of the 3 months are a week with no hormone, and that's when people would have a scheduled period every 3 months. So for patients that don't want to bleed every single month, don't want to have a regular period, which is important to some people, or if they wanted to have a better chance at not having cramping, and they wanted to, or they needed to decrease the amount of bleeding they were having because maybe it's bothersome, or maybe it's causing low iron. These are really good options for pills. And then we'll go to the next slide. I know that no one is going to be able to read what's on the slide because it's like teeny tiny language, but we wanted you to know there's a really awesome resource also with really great patient education sheets called the Reproductive Health Access Project, and we can include that in the follow-up email too. And it has this 1-page, thanks Erin, 1-page kind of guide to share with your patients and review for yourself for how people using the birth control pill and the ring can skip periods. And a lot of patients say, well, is that safe? Is it safe to skip periods? Is it safe to not have bleeding? And the answer is, if you're on a birth control method and you know that that's a side effect or that's something that you can achieve by using this medicine, it's safe. But if you weren't on any medicine that was causing you to skip periods and you just randomly stopped getting your period, then we would really need to figure out what's going on. And then I take out my uterus display, show you here. I take out a lot. And I show the inside lining of the uterus here, the dark pink part, that stays thin on these hormones that are in the birth control. So it's not like the inside lining of the uterus is just building up, which is a concern that a lot of patients have if they're not bleeding regularly. So let's go to the next slide. So another issue that I see with patients getting referred to me, and I don't even say where I work now. I work at UNM Young Children's Health Center. I have worked in school-based health centers in the past, but right now I work in adolescent gynecology at a pediatric primary care clinic in Albuquerque, and I see people from all over the state. And so what I see is sometimes patients are sent to me and they're like, gosh, I was put on this birth control pill so I could bleed less, but now I'm bleeding less in amount, but I'm bleeding a lot of days. And so we call that breakthrough bleeding. Sometimes if people are put on too low a dose of estrogen in their pill, we can see that they have bleeding more often. So one thing that we will often do for patients that come in on like a little itty bitty amount of estrogen in their pill, like a 20 microgram estrogen combination pills, we increase the dose of estrogen in the pill. So it's not to the highest level, but to what I would call like a medium dose, so 30 or 35 microgram. Not super relevant for social work, except to know if people are like, I was put on the pill for this thing and I'm actually just having this really annoying bleeding. Just know that there's a lot of things that we can do as clinicians if they wanted to stay on a pill to help them not have those annoying side effects. And changing a pill to a different dose of estrogen is one of them, but not the only thing. All right, we'll go to the next slide. There's also the option of pills for patients that have medical conditions that make estrogen unsafe for them. So I have quite a few patients that, just because I see a special population of people who have a lot of medical complexity. So some patients choose this progestin-only pill. You might have heard of it as the mini pill. So this is what some people who are lactating or breastfeeding or chest feeding take because they can't have estrogen at a certain point in their postpartum experience. So good thing to know is if someone's on a progestin-only pill, it doesn't have estrogen in it. And so every single pill is going to have the same amount of hormone every single day. And there's not going to be that like blank week unless they're getting a very new progestin-only pill that's drospirenone only, and that would be an exception. But I think that it's so new that we aren't seeing it covered by insurance a lot. So it's very likely that they would just have the one that's the same amount every single day. If someone's taking a progestin-only pill, they really have to take it within a 3-hour window every single day. So it's less forgiving and less good at preventing pregnancy if people are taking their pill outside of that 3-hour window every day.
Erin?
Yes.
Erin, my name is Lloyd. Just a quick question. I know that many of us are in the business of facilitating healthier relationships with adolescents, those of us that work in that exclusive population. At what point, perhaps later in the presentation, do you offer perhaps strategies or some sort of systematic way of adolescent couples talking about this? So maybe the male part of that equation might then facilitate with the female the importance of being responsible in taking the medication on a timely basis, which is the right thing. I understand that it's up to the female to make that decision, but I know some of my students that I work with want to be part of that experience. And when you've got that developmental maturity, and many of the males I work with are developmentally mature to contribute. At what point do you offer that, or will you offer that a bit later?
Well, that's not a part of this specific slide set, but I think it's a great thing to talk about. And I will just say personally, when I was a teenager, I was terrible at remembering the pill every day. And I had my boyfriend remind me every single day.
Right.
So I think that the most important thing is, your kids that you're serving. And we in adolescent healthcare, we love to just build up on resiliency factors. And it sounds like one of the factors that you see is mature, responsible, interested partners, or partners that have the potential to be that, really bringing them into the conversation. Like, I had a lot of patients who would want their partners or their friends to come in with them to their visits pre-COVID. And pre-COVID, I was like, yes, I will write a pass for those kids to come and be with you, to support you, because it's so important to involve whoever is in their support system, whether it's to help them, understand how a method might fit into their life. Like, I've had people that have their friends or family come in and they're like, you're not going to remember a pill every day. You think you're going to remember a pill every day? And some people are like, oh, she's very responsible. She will remember the pill every day,
Jen, even for some of the males I work with who want to participate in helping the female with the IUD the proper way, so that young boys become sensitive to that whole experience. It's not just participating in intercourse, but when you have students that have that level of maturity, both chronologically and developmentally, emotionally, it's always helpful when they're interested to offer that paradigm for them. So thank you for letting me share that.
No, I really appreciate that. Erin, what do you have to share about your
totally agree. I always offer for the partner to come into our visits. And I also, with my male patients, when I'm seeing them on their own for other reasons, we talk about all of this stuff, and I try to talk about if they have a partner or they want to hear about specific methods and how those work, to talk about it with them also. I mean, they are definitely half of the equation, right? And I think we sometimes forget to empower boys with this information and to talk to them about it and to let them be part of the equation.
And Erin, I'm glad you said that, because I work pretty exclusively with a male population, adolescents. So when you have that sort of gift in working with a population, you're sort of exposed to young boys that want to participate in that. And it's nice to give them sort of opportunities and create, templates, fertile ground, pardon the pun, right? Where they can start to experience what it's like to be on their way to an adult male. And I'm a father. I have an adolescent boy as well. And at home, we talk about that in a very commensurate way. But I run groups at the school where I work at, where we're able to facilitate that.
That's awesome. And I would really try to hook up with your medical providers too, and make sure, find out if they're willing to just see boys sometime for contraceptive counseling. Because I think sometimes we forget when we're trying to be like, pregnancy prevention. And we kind of forget that, that whole half of the population really needs this care also.
Right. Thank you.
Yeah, I like that.
It's really important.
When I bring the subject, I had an opposite experience where I was working with males and they wanted to have vasectomies because they felt that they weren't ready for children. They didn't know if they wanted children. They felt unwanted being born in their family dynamics. And so that was a really tough situation because I had 4 boys that were friends and they decided that they wanted to take charge. And then there was a period of time too where there was a male birth control. And I haven't heard a lot about that anymore. Is that still being produced or not?
So the condom is probably.
No, not the condom, but there was an actual pill like that girls take that was prescribed for boys. And I had a couple of students that were taking it, but then they left on to college, so I don't know what finally happened. But I know that there was a prescription for boys. And I haven't heard anything about it.
In the United States?
Uh-huh.
I've heard of some places using a very high dose of Depo-Provera for some incarcerated males, which is, in my opinion, not very ethical. But there's no other reversible male contraception available other than condoms. And I would say, I hope that adolescent males would not be able to access vasectomy services, just like we try not to do tubal ligation for adolescent females, because their brains are still developing in their frontal lobe. And, you know, I hear you say like, they thought they might not want to have kids in the future, but we know that typically we wait until someone's an adult to provide permanent sterilization, because ethically, that's not something that we can really offer as a service to people who might decide later that they want to be able to, and to have babies.
It was very tough, and
Yeah.
I finally had to form a large committee and get a lot of people involved because I didn't feel I had the capability of encouraging a young person into that path of decision making. But I was just wondering if it's still continuing, if that was an isolated incident.
Yeah, I mean, it might have been a clinical trial, but I can't imagine it would have been done with adolescents, because usually those are done with adults.
Okay, thank you.
Yeah, and then I wanted to just build off what Lloyd had shared, that when I was at the school-based health center, I would always love to see boys into clinic, because it was such a great opportunity not only to just talk about pregnancy prevention, but also to talk about STI risk reduction, sexually transmitted infection screening, how to talk about reducing risk of STIs and condom use with their partners and their friends. And sometimes we would have boys come in for emergency contraception. A lot, right, Erin?
All the time. Yeah, for friends or partners or whatever.
Yeah, and if they're coming in, and I would feel like a lot of times my guys would come in because they had been exposed to an STI. And I just always take the opportunity for any adolescent that comes in to do some anticipatory guidance about reproductive health. That's not why they're there.
Well, and I'll tell you, Erin, one thing that we pride ourselves here at the school is that oftentimes when you're working with a certain population, you've got to use terminology that's endemic to their age group.
Yeah. So
what I do with my boys, I happen to be a coach in a weight training class, so I get to interact with my boys there too. But I'm a psychologist by profession. But instead of oftentimes with our population, instead of using the terms penis and vagina, with my boys, it's, you know, if you're in heat, wrap your meat, or no glove, no love. And they love that. On occasion, they'll come back from the weekend and they'll say, hey, Dr. Vio, I had love, but I make sure I use a glove. And we make fun of it, but it's something that universally they're able to talk about, and they get the message, right? They get the message. So we use appropriate terminology, but try to get the point across. So no glove, no love, and they get it.
That's so great. And it's so helpful to get those messages from not just clinicians, right? Like, and not just medical providers, like any adult that they trust and that they have a relationship with, even if it's something as like short and sweet as that, if they're hearing it from multiple places, then it's helping reinforce that, like, this is how you can be responsible for your healthcare.
And boys at that age use terminology that's endemic to them. It's locker room talk. But if it gets the message across, and they can come back and share that, we know we've done our job.
Yeah, and then you're in such a great position that if they have questions or they need more information, you can help navigate them to where they need to go. So yeah,
Thank you.
super important. Yeah, thank you for your comment. Erin, let's go to the next slide. So this content, I have no idea if it's relevant to you all at all, but I'm just going to go over it because if you're in a position where you're in leadership in your school-based health center, or you know people who are, or you're like, why aren't we doing this at our clinic? This might give you an idea of how you can increase access to the IUDs and implants where you work. So we'll go to the next slide. Oh my gosh, this looks so itty bitty on my screen, so I don't know if you all have the ability to make it look bigger, but basically this outlines the different manufacturers and the different types of IUDs and implants and how much they cost. So you can see that a lot of these implants and IUDs can cost upward of $1,000. A lot of school-based health centers are sponsored by federally qualified health centers or rural health clinics that have the capability to purchase medications at a discounted cost. And so that's where it says 340B. That's the discounted price that organizations that have that special designation, usually just serving a majority low-income population, can access. So we're really lucky in New Mexico that we have a Medicaid program that allows for any clinic to be reimbursed for the cost of the IUD or the implant. And that's been the case for almost 5 years now in our state. It's not the case in every state. And so we really want people to know you can get paid for this work. And there's a way to bill for it, and there's a way to follow up and make sure you get paid for it. So if you all wanted to help increase access to IUDs and implants in your clinics, this is information to share with the people who make those kinds of money and medicine decisions. All right, let's go to the next one. So there are two different ways to stock IUDs and implants in your clinic. One way is to have them on site. And so they're just ready, like Erin was saying, for same day that someone comes in. Let's say someone comes in and they want emergency contraception. They had penis and vagina sex last night or 2 days ago without a condom, or condom broke or whatever, and they wanted pregnancy prevention. So they need to be able to access that IUD care right away. This buy and bill option of having the IUD available in your clinic helps facilitate people getting that care that they need. The other way is called pharmacy benefit, and that's a process that takes kind of a long time of someone coming in, deciding that that's the method that they wanted, or you can decide over a telehealth appointment. And then the clinic has to order it from a pharmacy far away to be sent to the clinic. So we'll go to the next slide. And so for the buy and bill option, the clinic has to have a pharmacy license to be able to have medicines on site. And then the clinic would order from, just like how they would order for Depo or the birth control pill, to have in their pharmacy. And it's that, not that the IUDs or implants are ordered in a patient's name. They're ordered just in general and can be used for anyone. Go to the next one. All right. So this is a question that we get asked a lot. Like, if our clinic purchases these and they sit on the shelf for, for years, aren't they going to expire? And then we're going to be out all that money. Well, usually we advise people that are just starting to have IUDs and implants in their clinic to start with a very small stock, like maybe one of each. And to know that the expiration date is not like a date that they have to like tell the patient, like, okay, in December of 2022, this is going to stop working. It's really like an insert by date. So as long as, if it says December 2022 on the box, it's like it needs to be inserted by that time for the device to be able to prevent pregnancy for the amount of years that we know that it can. And so for some of the IUD and implant manufacturers, they will replace the device if you see that it's about to expire. Just depends on what that is. Right, let's go to the next slide, please. This is a really roundabout long description of all the ways that ordering the IUD or implant, especially for one patient, can go wrong. So I'm not going to go into it because it's like super not relevant to your jobs, but just so you know, like if you work in the kind of clinic where a patient says that they want an IUD or implant, and then it takes like a month or two or more for it to show up, it's probably because the clinic is going through this process where the insurance company pays a pharmacy away from the clinic for the IUD or implant, and then it's shipped in that patient's name to the clinic, and that takes usually at best a few weeks. And that IUD or implant can only be used for that patient that it's been ordered in their name. It can't be used for anyone else. So if the patient changes their mind or decides not to come in, then you have this IUD or implant we can't use for other people. Go to the next slide, please. Okay, so I just said the IUD or implant cannot be used on another patient in the state of New Mexico. In other states, it's different. All right, and then here's some information about what you can do if a patient decides not to come in for their IUD or implant. Some of the manufacturers have a program for returning it. Go to the next slide, please. And then for those uninsured patients, there are a few different options. None of them are all that great, to be honest, through the manufacturers. If you have a patient who's uninsured and your clinic does not provide Title X services, which is like getting birth control for free from the federal government and then being able to provide that in your clinic, health department clinics in your community might be able to offer all methods of contraception without cost for adolescents. And we, Erin and Anna and I work for the Lark mentoring program that can provide stipends to clinics in New Mexico, specifically school-based health centers, to help support access to all methods of birth control for uninsured and confidential people. So if you wanted to learn more about that, please reach out to us. Go to the next slide, please. Okay. So this is the document that the Human Services Department and Medicaid put out in 2016, stating exactly how to bill to be reimbursed for the actual IUD or implant in addition to the visit. And so we're not going to go through all those details, but just know if this is something that you're interested in that you think would help your school-based health center, please refer people to us and we can walk them through every single step at a very detailed level to help make this work. Go to the next slide. Also, something that not everyone knows is that with the Affordable Care Act, and it's been like seconded by New Mexico State Legislature, all patients should be able to receive all methods of pregnancy prevention, of birth control, without having to pay for the visit or the medication. And so basically, there should not be a prior authorization that is required because patients should be able to choose whichever method they want without coercion or barriers to accessing that care. We'll go to the next slide. And this is a list of all, and this is federal policy and this is also state policy. So all of the health plans, including the Medicaid managed care plans, need to cover at least one type of birth control in all of these categories. And cover means the patient should not have to pay a copay, the patient should not have to pay for the visit associated with this care, and they should not have to pay for preventing pregnancy with these methods. Go to the next slide. Okay, and then the rest of these slides are very specific to clinical care and updates to evaluation and management codes, which I don't think apply to social workers. And so I'm not going to go through it unless anyone has any specific questions about it. So Erin, let's just go to the kind of the wrap it up slides. Okay. So if you or any of the folks that you work with are interested in learning more about reproductive health care for adolescents or for adults, we do every other week. We have a free webinar on Tuesdays at noon. The one that's coming up next week, our medical director, Dr. Helen Okendo, is presenting on complications related to IUD and implant care. And then we're also going to talk about another super relevant one, I think, for all people who work in a clinic is trauma-informed pelvic care. And Anna White, who's one of our co-presenters today, is going to be talking about that. It's basically how to make your clinic a more friendly environment for people to have pelvic exams or IUD care, especially if they've had any trauma history in the past. So we have webinars scheduled out through the summer, and we can include that information in the follow-up email as well. They're all free, and they all have free CME, but not the free social worker continuing education, unfortunately, yet. Okay, go to the next one. All right, so thanks for hanging in there with us. I know Zoom fatigue is real. And our program manager is Andrea Anderson. This is her email. Erin had put our emails in the chat as well. And we are scheduled to be with you all until 4. And so we are super happy to hang out and answer any questions or hear any comments about reproductive health care in your school-based health center setting. Erin, I don't know if there's any other slides. Was that it? Okay, great.
Really quickly, before we do the Q&A, I'm going to go ahead and do our little closing bit. So thank you guys again for that wonderful presentation and also your generous support of our school health community. A link to the evaluation will be sent out within 48 hours. I will include all of the resources and everything from this presentation once I get those from your presenters. Once the CU credits are approved, they'll be sent to you in a certificate, and it states the amount of CEUs earned on the certificate. And I'm going to do the attendance check now. All right, perfect.
Miss Alicia.
Yeah.
So this is my first time attending. I imagine if I don't navigate this properly, you'll let us know.
Oh, definitely. Yeah, you're fine.
Okay.
I got everybody's answers in, so you should be fine.
Thank you.
Yeah, no problem. And again, thank you guys all for attending. And if you have any questions, now would be the time to ask them.
I just want to say thank you for indulging me and allowing me to incorporate the male perspective regarding adolescent boys. It really does go a long way. Thank you.
Oh, well, thank you for sharing your experience. And we love it when people interact and share kind of what they found to be super helpful. And I feel like one of the saddest things about my current practice is that I don't get to see boys because including them is so important. And
Right.
I will say during COVID, one way that I've been able to include them more is on like the patients FaceTiming them in or including them on the phone. So it's not the same, but they can still hear the information we're going over and contribute and be there to support their partner.
Absolutely. Thank you.
Any other questions or comments about anything related to reproductive health care or how we can help support you? Lizette Sandoval says, I serve the Mexican immigrant community. Culturally, this topic is difficult to discuss with parents. How we've been the most successful? Yeah, I work with that community too. I love working with this community and super familiar with including parents in these conversations. And Erin does too, and so does Anna. So Erin, what do you think?
To be perfectly honest, I have a lot of these conversations without the parents. So I find that I don't have an opportunity to include these parents very often because I am in a school-based health setting situation where I see the kids by themselves a lot. And I think there's a lot of misinformation, and I think there's a lot of, I think in the immigrant community, sometimes there's priorities we don't necessarily think about that around contraception. And I think the kids have a lot of those priorities also, not just the parents. So I think kind of some of the topics we've been talking about today about really eliciting patient priorities and asking them about what's important is really, really key. Because I've found, you know, I have some patients who have heard, you know, myths from their parents, or they have, you know, they really want to have a period because that's really important to their mom, etc. And I think just staying patient-centered has been the most helpful for me, but I don't have a great answer for working with the parents because I don't do it that often. Jen, do you, or Anna?
Yeah, I do for sure. So I, because I work in a pediatric clinic, most of my patients come in with their parents or guardians. They don't have to, right? With the reproductive health laws that we have in New Mexico, there's no minimum age for consent for reproductive health care, and we can provide confidential care for those who are needing it, who are minors, which is freeing for us. But the way that I set the tone at the beginning of my visit is I say, hi, I'm Jen. I use she, her pronouns. I'm a women's health nurse practitioner. And what do you like to be called? You know, first addressing the patient, and then who's with you today? And then, great, thank you so much for being here to support your kid. And how it works at this visit is we're all going to talk together. And then there's going to be a point in time during our visit where I'm going to talk one-on-one with the teenager, because they're almost an adult and I really want them to be comfortable in the clinic setting. And so we don't want to just spring it on them when they're 18. We want to give them these opportunities to practice. I'm not like, we're going to talk about sex and drugs, but we are. But we just do that, you know, with the parent not in the room. And then I can find out the information about, like what Erin was saying, what the patient's goals are versus what the parent's goals are. And sometimes they're the same and sometimes they're not. So what I do is I like asking the teenager, hey, like, we're going to talk about some of these things in terms of managing your period problems or preventing pregnancy, or however you want to frame it and talk about it with your parent. But what do you want? How do you feel? And how do you think this conversation is going to go? How can we have this conversation and involve your parent in a way that is going to be more comfortable for you? And a lot of times the kids have really helpful tips, like, let's only talk about it as something that will help with my periods, or I think that my mom is not going to be okay with it, but then maybe we can go home and she can talk about it with some like aunties and grandma and whoever, and then come back next time. And then maybe it'll be okay if she gets some time to think about it. So I just really look to the kids as the experts in their own families about what their approach would be and what they want, right? Anna, what do you think?
I agree with that. I think it's really engaging the kids in kind of what they think might be okay with their parents and not, because I think they know their family structure the best. And I think a lot of them know how they want to engage their parents. And I wouldn't say it's cut and dry of like, most kids don't want their parents involved. I would say it's actually the opposite. I think a lot of young people want to engage their parents in this type of decision making, but I think that they're pretty aware of what's the most sensitive issue within the family. And so I think giving them that ability, and then that also helps with kind of confidentiality, which is such an important concept for this population. So obviously if they're wanting confidential services, then we also have to navigate that. And that's what a lot of school-based health centers do, that, you know, in a really great way, as well as the Department of Health, is they really navigate how to provide these services without informing parents, because that also could be a piece to the equation.
Yeah, and I think just asking the kid, like, how involved do you want your parents to be? And if you want them to be involved, and I did this when I was at school-based health, I would say, do you want to call your mom and have her be part of this visit? Do you want to call your mom and talk about these specific things? And what do you want me to talk about? And what do you not want me to talk about? Because I don't have to talk about this in terms of pregnancy prevention. I don't have to talk about the fact that you've had sex already. But if you want me to talk about these medicines in terms of non-contraceptive benefits, not using those words with kids, right? But in terms of your cramps or your PMS or whatever, like, let's talk about the parameters in which we're going to discuss the topics before we go into it. So they know, they can trust that we're going to keep their, their confidential care confidential. Did that help, Lisa? Or since you work with this community, what would you like to share from your experience, if she's still on the call? Oh, there you are.
I am.
Hi.
Yeah, I work in the South Valley.
Oh,
And so
yay.
so definitely close to a Trisco.
Yeah, me too.
Yeah. And so yeah, this topic, it can be difficult. Also, like Anna was sharing, sometimes parents are really willing to be involved. But I was just more curious to see if there's anything else I can add to my toolbox that has helped you guys. So thank you for sharing.
Is there anything that you found that we didn't say?
I think the biggest thing for me has been being able to speak Spanish. I don't know if that has been a barrier in the clinic for you guys, but definitely being able to speak Spanish, speaking the language. Also always seeing myself as an ally, like, some parents would be like, better not be giving my kid condoms, and just being like, hey, like, let me tell you why. It has been a struggle at times. The parents will say like, I don't want you talking to Miss Liz anymore because she's giving out condoms. But just having those conversations, always fighting for our kids. I had asked earlier about the Plan B, because there has been times where they're like, Miss, I don't have $50. Like, how do I get to Walgreens? And I'm like, no, hold on. Like, let's figure this out. But because our providers were only there 1 or 2 days a week, it would be really hard for them to access that. And then we're thinking about transportation and all of that. So luckily I have, I'm sorry.
Oh, sorry. Go ahead.
Luckily, I've been able to build good connections with the health department, so that we've been able to get them in, as well as kids that have already graduated, and they're like, Miss, like, can I still have access to all of this? From what I understand, I think it's up to 21 years old. So, but anyways, it's just a lot of navigating and stuff, and so I really appreciate all the information you guys have shared.
Where in the South Valley are you? What?
I'm at South Valley Academy.
Okay. You can also send any of your kids to us at Trisco. We have a provider there full-time, 5 days a week. We'll see any adolescent for confidential services and have coverage for them. And we see them we can also see them after they graduate. So because we do full family medicine, I'm going to plug us as another resource.
Please. Thank you.
Yeah, but Lisa, if they can get to the pharmacy, whether they have insurance or not, if they have a prescription, if they use goodrx.com, it should be around $10. So it's really important to know, but only if they have a prescription. And if they're like in a place where they think they might want to use emergency contraception, I just always would have the provider send out the prescription ahead of time, just in case. So it's at the pharmacy and they understand how to access it. But yeah, I found that speaking the language is super helpful as well. And then I always just find too that like planting the seed and being open to, like, I hear that, like, reflecting back, like, I hear that you don't want to consider birth control at all for your child. And I totally respect where you're at. And I want you to know if anything changes or you change your mind, I'm here to support whatever is best for you and your family. And sometimes I have people come in for incredibly severe menstrual cramps. That's where they're at. The next time they come in, they've talked with their community, kind of gotten comfortable with the idea and been like, okay. And then if they say things like, I'm really worried that this is going to cause problems with future pregnancy, which is a huge concern, I always say, like, I really, really share your concern about that. And I would never want to do anything that would impact your kid's ability to get pregnant in the future. So just try to be really, like, anytime I can find a shared goal, being like, yes, me too. We're on the same page, I find that helps build trust and rapport. And I mean it too, which I'm sure you do too. All right. Any other questions or experiences that people want to share? You can always write to us, and we'll have our contact information. Super happy to schedule special trainings with your staff and your clinicians, your admin people across the state of New Mexico. We're doing a lot on Zoom these days, you might imagine, but we're back to doing Exponent trainings in person if you needed that too.